welcome everybody, and just as a reminder of why we are all here. Between the poorest and the richest parts of our ICS, there's a 9-year difference in life expectancy, and people in the poorest areas are expected to live with their long-term conditions for 10 years longer than from the richest parts of our system. A Black woman is still 4 times likely to die around pregnancy. Diabetes, what's happened with the COVID pandemic, has been laid bare for all of us to see. And LGBTQ and trans people are up to twice as likely to have committed suicide or self-harmed within the last year. It's the reason why we're here. And in the words of Mahatma Gandhi, the true measure of a society is how it treats its most vulnerable. So what has our response been to this? Our response has been, what are we missing? And to propose a system-wide change, but also deep and true co-production to change not only how we do things, but to change the outcomes and to reverse all of those things that several reports, including the landmark Marmot report, tells us we should change. So not only are we going to think differently, but we are going to do differently this time. And this is not about us as leaders, but as Fanwell likes to say, it's about inviting the novices to be experts, to co-produce a strategy, to co-produce a way of doing things that changes the impact and the outcomes of those things. So in that, with that having been said, I'd like to introduce us to all the professionals in attendance. But in a lot of ways, we are all professionals in this, in that we are starting from ground zero to change these outcomes around. So firstly, Claire Corbett, our ICS Cancer and Transformation Program Lead. Peter Holloway, who is our transformation lead within the CCG and the ICS. Dean Ono, who leads the CCG on multiple things, including sort of diabetes. Robert Permans, who is the NHS Diabetes Prevention Program. Gail Cardy, the Transformation Project Manager on Mental Health. And Ben Solway, who, if I had to list all the things that he's done within his time on the CCG, we would be here all day.
Thank you, everybody. My name's David Akinsanya, and I'm the lead for equity working with the ICS. And I'm here today. Dean was talking about change and changing the way that we do things. I'm really excited that my job allows me to be involved in all of that. And one of the things that I've been working on with the team, and that includes data analysts, researchers like Sharon, we've been working to support a number of grassroots organisations, and we've helped fund them to hopefully change some of those health outcomes. So I've got a little film. This film doesn't contain all of the projects because we've only got a 10-minute slot today, but this film should give you an idea of some of the projects that we're working with over the next 2 years. So can you run the film, please, Siobhan? Thank you.
North East Essex ICS Community Ambition Programme is funded by NHS Charities Together and is developed and run in partnership with the Colchester and Ipswich Hospitals charity. The programme funds 6 small local charities to begin to address some of the inequalities in access to health and care and their communities' health and wellbeing outcomes. This film explains a bit more about each of the projects and their aims. The Bangladeshi Women's Association of Essex, BWAE, aims to remove barriers accessing health and care amongst the Bangladeshi and wider Muslim communities in North East Essex. This community has suffered significantly during COVID, but there are also historical barriers to accessing health and care. Their Community Ambition project will help BWAE reach many more individuals within their community, tackling health inequalities and to improve health outcomes.
This project is trying to look at the health and well-being needs of our Bangladeshi community, primarily Bangladeshi community and Muslim community. And we are trying to, one of the first things we're going to do is identify the needs of the community. And once the needs is identified, we can work out with the NHS to talk about the access to service and access to information. There has been no research been done into the needs of the community. Although the organization, Bangladeshi Women's Association, SX, has been going on for 20 odd years, and we have attended thousands of meetings, not until recently, and after the COVID, that COVID has shown how disproportionately the BME communities were affected by COVID. I think we were not listened to, we were not taken seriously until recently because of COVID. So we are trying to establish a need, access to information, access to public services that our community needs, because there's so much need out there, but that's not been ever understood or recognized.
The Unity Centre was created with the support of Ipswich and East Suffolk Clinical Commissioning Group and provides a local community hub for Black, Asian and minority ethnic communities in the health centre in the Witton area of Ipswich, which is one of the most deprived areas of England. The hub is a consortium of 4 charities delivering projects to people across different age groups. Phoebe supports Black, Asian and minority ethnic women to improve access and quality of support for women receiving healthcare services. This project provides a dedicated maternity support worker to help the women during pregnancy and in early motherhood. Suffolk Refugee Support helps refugees in the Witton area in addressing the health inequalities they face. They will focus on providing practical support and referrals to other specialist services and help people make lifestyle changes around risk factors to their health, such as diabetes and obesity. Active Suffolk will be working closely with health and care services and local ethnic minority communities to help people to be physically active and better connected. Fresh Start New Beginnings supports children and young people who have been sexually assaulted and abused. They will be focusing on helping vulnerable minority ethnic children and young people to overcome the additional barriers they may face in disclosing and reporting abuse. Let's look a bit more closely at one of the projects, Phoebe, which is doing great work with mothers and babies and young children, linking in with local statutory maternity services.
The work that we will be delivering is with Black and minoritized women and their babies. We've employed a community maternity advocate, and she will be working to support women who, with their babies, need extra support in accessing resources, in offering each other peer-to-peer support, and this fund will really go a long way enabling them to seek help and support during pregnancy and after pregnancy.
It is very rewarding working for Phoebe because I get the chance to make a difference to these women and their families' lives.
The Community Ambition Fund has enabled us to realize our ambitions as a small charity. We want to continue to make an impact in Suffolk, and we are very grateful. Thank you.
And now let's find out more about what Active Lives will be doing in the Witton Unity Centre Hub, which will include a focus on reaching into the local ethnic minority communities.
So we'll be delivering the Active Wellbeing Service at the Unity Centre. The Active Wellbeing Service is a programme designed to support older adults who are currently inactive. Specifically, we want to work very closely with primary care, so the GP surgeries serving the local area, social prescribers, leisure organisations and facilities who are also working within this area. And the idea is we'd like to see clients or older adults who are currently inactive that may have additional barriers which are preventing them from being more active. This could be long-term health conditions, it could be transport, financial, it might be confidence and understanding and motivation around being more active.
This joint project by ISCRI, the Ipswich and Suffolk Council for Racial Equality and Volunteering Matters, focuses on empowering young people in Ipswich to have a voice in their health and care. ISCRI is a long-established charity which first started supporting local people in 1977. Volunteering Matters Ipswich enables local children and young people to have a voice through social action and has a very successful mentoring programme for those young people who need additional help to achieve their aims in life. This project will engage young people from minority ethnic communities in Ipswich to co-produce health-focused solutions to begin to address the health inequalities that exist in their communities. This will lead to a network of 60 young BAME health ambassadors across Ipswich.
Volunteering Matters and the Ipswich and Suffolk Council for Racial Equality have been funded by the Community Ambitions Programme to the tune of £44,000 over 2 years to work with young people in Ipswich to focus on their health needs. We work with people from Black, Asian and minority ethnic communities to improve their participation in service provision and to educate organizations and individuals about the needs of people from those backgrounds. With this project, we are looking at bringing together young people and health service providers to inform the needs of young people and to improve the way that health services are delivered towards young people from minority ethnic backgrounds. So this is an exciting opportunity to work with our health services to educate them about how best to engage with young people from our minority ethnic communities and to create a sustainable model moving forwards which will allow these services to work better with people from those backgrounds.
The Ladies of SENS project aims to improve the health and well-being of local African women by encouraging healthier lifestyle behaviours. This project will provide women with the tools tailored to them and their lifestyles and cultures.
We are the ladies of Suffolk, Essex and Norfolk, and we run the African Well Women project. We received a £15,000 grant from the Community Ambitions funding to deliver health coaching and exercise groups for women who want to improve their health and well-being. We wanted to run this project because the 50 women who belong in our group were really talking about how their lives had changed since coming to work in the UK. Our group is made up predominantly of nurses and social workers, and the impact of working shift work and the impact of raising families here and having a busy lifestyle, realized that we are not eating as healthy as we could, and that has taken a toll on our health and well-being. And so we decided that we wanted to come together and to support ourselves, and the Community Ambition funding has enabled us to actually support ourselves in the way of health coaching and exercise training. We are working with a specialist in African food, and they are supporting us from a dietitian point of view and nutrition to support us to really look into our own traditional foods, to teach us on the nutritional values, to teach us around calories and portion size control, so that we are in control of what we're eating and we're influencing our families as well.
These projects are really innovative, and we want them to continue to grow from strength to strength. All of these projects work in and with communities whose needs have been historically neglected by health and care services. What we learn through these projects about best practice will benefit not only these communities, but many other marginalised groups as well. These organisations are also a source of expertise for statutory health and care services, so we want them to continue to build relationships with local health and care. By having a voice, these groups can ensure health and care services become more culturally competent, flexible and sensitive to the people's needs. We hope this programme will go some way towards ensuring better health outcomes for everyone.
Incredible sort of projects. I think brilliant examples of high impact sort of projects, incredibly low cost, co-produced and sustainable. I think we're now going to ask of the audience whether there's any questions for Sharon and David about these projects. I think they speak to themselves in terms of aiming upstream and, more importantly, being co-produced. So any questions for Sharon and David on these?
My question is around motivation and recruitment. You know, how one sustains that, and do, you know, for example, in the gym, that fantastic boxing, you know, is there a ripple effect? Do they go then back and say, come on, you know, join in and come the next time? And is that how it grows, slowly but steadily, with a word of mouth, and, you know, the faith that it's a good thing to do? Is that how it works, or do you have to, you know, spend money advertising? How do you recruit and motivate?
The groups have budgets for things like you know, within their funding for things like marketing, but because it is high, you know, the one you're talking about is, you know, kind of hyper local, then they can use their local community networks. The other groups, like African families, Bangladeshi women, they're very embedded within their communities, and faith groups as well as voluntary sector organisations. So we've got Godwin here as well, who I can see. And they will use their networks. But I think the most important thing for me is what's good practice for one group or one sector or one community. It's just best practice for everybody. So I think we want that, all that stuff to spread, not just within those communities, but between them and across the ICS.
I was just going to say that actually the other thing that's been really important for working with the groups is the amount of support that we are able to give them, because these aren't, it's that some of these organisations haven't got constitutions, we're very small, and, you know, in terms of governance, it would have been very difficult to give them monies in the past, but we've made it work because organisations like this do have the contact with their communities, and they're the communities that we need to work with. So all in all, I think it's been a good exercise in finding out how we can work in partnership with these organisations. And to be honest with you, they are very grateful and very happy to be doing this work. So it's something that there's good faith on both sides.
Yes, I will just double down on that. It's those buzzwords around sort of control, ownership. If within the statutory sector we try to micromanage and control every bit of it and don't trust these communities to know how to recruit and how to implement the solutions, then they simply don't take it sort of forward. So yes, brilliant examples. And I think if we thought 12 months ago that we would be in this position as a catalyst going forward, I think we'd all be surprised. So yes, well done.
Since the first What We're Missing event in summer 2020, we've had to think hard about inequalities and what our system should be doing to achieve equity for all of our people and communities. So we held a Thinking Differently event on race inequalities in July 2020 to explore those issues. What we did was we reflected on the impact of COVID on marginalised communities in our system, learning review in September 2020, and we recommended that we focus not just on the many, but the few. During that time, we had a film competition and community conversations in our How Do We Heal campaign in the summer of 2021. We led on inequalities in the COVID vaccine programme, which started in early 2021, and we learned a great deal. Can I have the next slide, please? Next slide, please. So learning from thank you. So learning from our vaccine programme, on the 9th of December, we administered the first vaccine in our area. On the 18th of December, we completed a first draft of our Equality and Health Inequalities Impact Assessment, covering all characteristics and factors such as deprivation, rurality, and it was very influential regionally and nationally. On the 15th of January, we started taking ethnic minority elders to the vaccine process and saw the difficulties they faced in access and language barriers. On the 16th of February, we took representatives of ethnic minority communities through the vaccine process to ask how it could be more accessible and culturally sensitive to them. Between the 25th and the 28th of February, we introduced the first co-produced clinics with local groups. This is a picture of the Chinese society in Colchester, who were experiencing so much negative treatment by the public at that time.
Sorry, Siobhan, if you could just move those forward. Thank you, Siobhan.
Yeah, I'll just put,
okay.
That's it, thank you.
So on the 10th of March, the vaccine bus started operating, providing outreach to local communities. They also offer health prevention advice as part of the service. In April, we started to see the curve turn on uptake of the vaccine. The blue curve is white British, the red is Bangladeshi communities. There was a rapid increase in uptake, showing the difference that we'd made. On the 21st of May, the 1 millionth vaccine was delivered in Suffolk and North East Essex to Mr. Mia in Ipswich. From the start of our work to reach out to local communities in early 2021, when we saw the data on update changing significantly, it was just 100 days. So in just 100 days from the point of us making our health impact assessment, we managed to make a really big difference to the whole vaccine programme locally. And as I said, we set an example both regionally and nationally. Can I have the next slide, please? Next slide, please. Sorry. So taking what we learned from the vaccine programme and what we achieved in 100 days, we started to look at how we could move towards not just equality, but equity by encouraging local organisations to create their own 100-day challenges. We developed workshops for local organisation, and we also managed to involve people with lived experience as part of that workshop. Can I have the next slide, please? So in supporting the development of the 100-day challenges, we've had a really good uptake of our workshops. We've reached out to voluntary organisations, people within the NHS and people in social health and care, as well as the voluntary organisations. Can I have the next slide, please? Okay, so on our website, we've created a website that's got sunflowers for all of the organisations that have taken part, and we're following that up. In fact, I've been sending letters out to people to find out how they're getting on with their 100-day challenge. We weren't asking them necessarily to do anything big. We were asking them to think of an issue that they care about and try and make a difference. So, and the last slide, I think, is about accelerating our approach to health equality. We recognise the need to continue to change the culture in our system to one of health where equity is at the heart of all we do. We've committed to equality and health inequality impact assessing our own major programmes, and we'll publish these on our website so we can be transparent and accountable to local people. Equity is not the cherry on the top, it's the raspberry ripple running through everything that we do.
Hello, yeah, I'm Sue Conker. I'm co-production coordinator at Healthwatch Suffolk, and I work alongside my colleague Amanda, and really importantly, we have a small team of co-production ambassadors who bring their lived experience to our team, and I'm really pleased to have been asked to attend today and to introduce the breakout rooms. So don't you worry, you'll have time to have your say very soon, which I'm excited to hear in my breakout room as well. And you've heard the word co-production today so many times, and there's been some excellent examples of it as well. So I'm just going to talk very briefly about what co-production is. And it is a way in which we work together, where everybody is really truly involved. So it's where people who use services, so patients, carers, staff, and and anyone who has a lived experience of just being a human being or a person within our society, we draw upon our experiences to work equally with professionals and with decision makers in health and social care, and we work together to design services, to improve services, and then eventually we learn to evaluate those very services. So as you can imagine, co-production really must go from the planning and the design all the way through to the monitoring and the governance and the evaluation, which is exactly where co-production needs to fit, as David said, as sort of the raspberry ripple through the ice cream. And organisations, when they're wanting to do co-production, it's all about listening to a really wide range and variety of different views. So not just the easiest people to find, not just those who are already there and sort of well informed. So it's an opportunity to work really creatively and innovatively in our system and to co-produce what the future looks like. And co-production is actually in our legislation. So firstly, it was in the Care Act of 2014, but most recently it's within the proposals and the guidance for the new Health and Care Bill. And I found this last night. NHS England has published a nice definition in June this year following the government proposals. And they say that by co-production, we mean people, family members, carers, organisations and commissioners working together in an equal way, sharing influence, skills and experience to design, deliver and monitor services and projects. Quite a long sentence, but it does encompass quite a lot of the concepts of co-production. So we're going to go into our breakout rooms where you can use some of your experiences and use the perspective that you have as a member of staff, as a patient, as a carer, or just as a person. And if you're able to also engage with some thoughts around what someone else's experience or perception of the services might be as well, might be quite an interesting way to look within the different services at different perspectives as well. Maybe if you can represent somebody who hasn't been able to attend today, that would be really useful. We've got 3 rooms, so a diabetes room, dementia room and a cancer room, and I think someone's been very busy in the background allocating everyone to these rooms. There'll be a chair of the session and there'll be someone in there to take notes. They'll be able to introduce themselves at the start. There's not going to be enough time to do a round of introductions for absolutely everyone. So I think it might be useful if just before you speak, you say your name and sort of the background that you come from. And there is a raise hand function, which I'm sure you're all aware of. So we'll be using that today as well. And we'll facilitate for about 30 minutes. You'll have a 5-minute warning, hopefully. And then we'll be coming back and feeding back what the discussions have been like in the rooms. So if you're thinking in the rooms, if you want to speak at the end to summarise what's been said, that would be really helpful. So do make sure somebody's nominated. We've thought of 4 questions for us to consider within the conversations. And you can kind of let the conversation go naturally, but if you want to consider answering some of these questions, might find that helpful to sort of aid and prompt where the conversation goes. So the first one is, if you could advise services or professionals to change one thing to improve access, what would it be? The second one is, describe a positive experience that you've had that services or professionals could learn from. What are the top 3 tips that you would give to ensure services are inclusive of all diversities? And finally, how could different services actually join up and integrate better than they are doing at the moment? So as long as I've covered everything, ready to open the rooms.
Basically having access and equitable treatment for whether you're diabetic, whether you're type 1 or type 2, for everyone going forward. I hope I've captured that, David. The other thing was for the African and Black community, there are some blanket courses that are being done, pre-diabetic courses that have been done. I've actually been on one myself. Some of the other people in the group had, and find it's a lot of blanket information instead of having it culturally sensitive to the needs of the person who attends the group in terms around the foods. I found that myself, having done the pre-diabetic course myself a few years ago, and so did one of the people in our group. So it's actually ensuring that there's some ongoing health management for those people, so they've got something in between, not just a 6-month follow-up and then nothing, but having ongoing. And to capture another a case that was mentioned around having ongoing emotional support for people who are diabetic, even though if they've been diabetic for some time, to have that support with the holistic management of their treatment, whether they're pregnant or whether they're of a different minority group, you know, having that ongoing support going forward. I hope I've captured all that we were saying. If there isn't, please chip in, my group.
Yeah, I would just add, thanks very much, Shirley. That there was just something about when we do the education classes in the world of diabetes, making sure that they're actually culturally balanced, because at the moment there are, and Mark, I'm going to use your words here. We've got a one size fits many, but it doesn't fit all. So we have to sort of find a way to make that work. And I would just add as well from David, who sort of gave us a bit of an interesting background about the diabetes service. He was talking about the fact that he believes type 2s are not treated as well as type 1s. And as an example of that, if you're a type 2 but insulin dependent, at the moment you can't get free continuous glucose monitoring. But if you were type 1, which he originally actually was diagnosed with, he could have got a free continuous glucose monitor. So, you know, it's just interesting from a patient perspective how just one decision can totally change the way things are looking. In terms of question 4, which was different services joining up, we did have a short debate about maternity services. And how the maternity services link up with the diabetes centre and making sure that they're communicating well so the patient gets very good care. I think we had, I could go on. I don't know how much time we've got, but we just had so much stuff that sort of appeared in a very short period of time, and we could have done with another hour as well.
Okay, that's great, and really great to hear you had such complex issues being raised, and maybe there is an opportunity to continue those discussions, maybe with more people with lived experience as well, to get different perspectives on that. Okay, the second group, dementia, please.
Our group had some incredible conversations, and we said that some of those questions, those 4 questions, Sue, linked very well together. So we kind of answered them as a sort of a collective. One of the things that we discussed was how important an individual is, any individual, and actually think about what's needed. We had some great examples of, if you worked in another industry, the customer is the most important, what they think, what they care about, what support they need. So I think it's about really focusing on that and understanding, having kindness and patience and inclusive and understanding. We did focus quite a lot on positive experience, but there's also quite a bit of negative. We had some really good conversations. Faniel before has supported some amazing conversations in the community. Unfortunately, they weren't followed up, so that's really disappointing. So from my perspective, and we were all saying that that's the most thing, is to go to the community, because dementia means something different to each of the cultures, and each of those sort of ages as well. So sometimes, and it's about taking our diagnostic services and our pre and post diagnostic services out to the community to find out how they want it delivered, how they want to have that experience, rather than asking them to listening and then still deciding what we want to do anyway. So I think it would be really good, and it could be different for every group that we work with, and that's really important to understand that, because although there is a difference, we do want to offer that service needs to be equitable across the system for everybody. So I think we wanted to also share ideas. If you can do one thing and it's something that works well, let's share it with other individuals and improve it for everybody. And as Ben's just put in the comments, is the patient is the most important, and working with them and their experiences will help us change these services. And it's about listening to everybody and also how they engage with each part of that dementia process, where they join it and how much support they get or don't get, and how we can do things differently. Sue, you've got a question. You were in our group. You've got some comments, sorry.
Sorry, no, just quickly. Hi, Sue Hughes. I'm the chair of the Dementia Forum and the Dementia Action Partnership. I'm here to listen and learn. But there are just two little things that might be helpful to add. Gail's got access to, there's a game called Staging Post and the Game of Life, and it's a reminiscence game, and it's available to people for free. And it's there to foster discovery and understanding and appreciation of different people's lives and cultures and traditions and faiths. So that's something that's out there that can be handy if anyone wants it. And also through the partnership, we're setting up wellbeing walks for people with dementia and other people, but with dementia trained leaders from next April. And we want those to be walks from communities, around communities. We are not talking a big ramble in the great British countryside. We're talking a little pot around town or whatever, reminiscence walk and a guided walk. So if you have any communities or places from which you would like those to go, it's been run by One Life Suffolk Health Walks, which is part of public health. We want them to go from dementia friendly cafes or something, so there's some respite for carers so they can have a little break. So anything like that we can help with, please just let us know, and Gail can put you in touch with me, or you can find me, and of course we'll do that. Thank you.
Yeah, thank you, Sue. And one of the other key areas we were talking about, which Louise raised, was about training and understanding, and the workforce having to understand, you know, there are different needs for each community, and actually everyone needs to have the same support. It should be there. So it's about really doing that true co-production and having people there right from the beginning. And Ben says help communities develop dementia care, support patients and carers where they need it. So I think there's so much knowledge and information out there that we can learn from. And as a commissioner of those services for diagnostic and pre and post diagnostic, as well as the dementia intensive support teams, I'm keen to understand how we can change things and do things better. And for people like Faniel, I apologise it didn't work well the first time, but I would value taking all that learning and develop it, because it's like you said, you shouldn't have to do it, but it's important that we do it and really listen this time. And I really would like to see some positive changes. And there's lots of things to think about, also about going into care homes as well, and how they support individuals when they go into those care homes, the food, the religions and everything. I've had some quite challenging conversations with some families because it's just been such a challenging experience. So I'm very passionate about this. I've seen what happened during COVID. I supported carers and unpaid carers, and I've seen what that impact has. And I have family members who have had their own personal experiences which aren't great with sort of services. So I'm really keen to do everything I can regarding dementia and anything else. And I really do believe in true co-production. We're not the important people, you are. So I'm happy to support anything going forward with dementia.
I'm really excited for the dementia work across our ICS. Actually, I think it's got lots of movement and potential, and I think it's all down to the passion that people have, and being able to kind of feel that you can keep pushing and pushing even if progress might be slow. I think it's an area where we shouldn't let it stop. There's a real potential for co-production in dementia care. Okay, finally, it's the room that I was in is cancer. I think we're hopefully going to have to all chip in with the feedback because we didn't agree it was going to be talking. I think we thought about it in lots of different ways, quite more creative ways of thinking. We were thinking about the equity in different ways that we can detect cancer and also treat cancer. We talked about co-production really should be a focus when we're thinking about where the resources can go, and being quite honest and transparent that maybe resources might be lower than they really could be, but it's about co-producing where those resources can go and meeting people where they are. So go to places where people are already waiting, for example, within primary care or even within charity and voluntary sectors. We can link up with other services, for example, sexual health services, where people are maybe more easily able to access something like a drop-in centre. Has anybody else got any of our key points to add in from our group, please?
Access. So we spoke a lot about the area before the GP. So really thinking about accessing service differently, and how we go out and do that, and thinking about our resources and our assets in our community and how we utilise those differently. So the real space before the GP.
Yes, I think for us, we sort of later on introduced a little bit of challenge in terms of the inverse care law and how we need to put our resources where the need is greatest. It will not only impact the outcomes that we get. It will mean that the NHS, and the social pound is spent in the place that it can have the most impact and create the most value. Pete sort of highlighted that there is quite a lot of investment within the cancer space sort of at the moment. So I think as a system, we need to be thinking, where can we deploy those extra resources to places where the outcomes are quite sort of stark. I think for all of the 3 rooms, it would be a shame if the breakout rooms just ended there. Part of the initial pledge of what are we missing would be what was not only co-producing the strategy, but I think a lot of what we've heard today should sit within a strategy and should be part of the planning, the doing, right through to the assurance. So I think as a follow-up, it's and I'm just suggesting it, the intelligence that we have in the breakout rooms and around this table at the moment shouldn't be lost just on this event. They should go forward into informing how we deploy the resources going forward.
One of the things that we've kind of committed to as an integrated care system is the importance of equality and health inequality assessing the kind of major programs that we have in the system. And the way that we've gone about that isn't just to equality impact assess, it's also to identify where there's mitigations and make sure that we hold one another mutually accountable in the system for following those through. So that's a really useful kind of vehicle to do that work, and it needs to be very open and it needs to be quite dynamic, because we continue to learn as we go along, don't we, about inequalities, but that enables us to have some structure to keep place on that. So we've already begun some of that work. We've got equality and health and equality impact assessments across quite a number of our major programs already. We're currently working very hard on looking across the elective surgery recovery, across our digital program. Obviously vaccines was a big area where that equality impact assessment drove a lot of that discipline, really, about making sure that we address things. So just a suggestion, we need to kind of reclaim the world of equality impact assessments and sort of make them the vehicle and the tool that enables us to do exactly what you're saying, Dean, which is to be objective, to make sure we understand the issues, and then hold ourselves as a system accountable for making progress.
The last bit of the feedback, we're actually going to revisit each of the rooms, and I'm going to ask the professional representatives of each area, so maybe the more clinical, if you are in the room, just to feedback to us on any points that you want to take back from the discussion, anything that you might now want to implement or even have a think about co-producing. And if you could revisit some of the progress in 3 months' time, what sort of thing would you be wanting to look at and measure? So I'm going to go back to the diabetes room.
So the thing, while I was covering the diabetes prevention program, so obviously there was a large proportion of the conversation that was discussing people who are actually diagnosed with diabetes, of course, with David himself. So that was sort of outside of my remit. Good thing for me as feedback was the fact that people were discussing about making services and courses available for multicultural, people from different backgrounds, covering different all populations, whether they're from affluent areas or from areas potentially of poverty, if that's what you want to call it, or deprived areas, probably a better word I should say. And it's good to know that the diabetes prevention program and Xyla Health and Wellbeing do cover all of those aspects, and we're not a service that would essentially make it difficult for certain people to access the service as well. Dean's got his hand up there, so he's probably going to describe it a lot better than I probably can. So
yeah, I have to be fair to Rob. I mean, we didn't really get much opportunity to get into the pre-diabetes world, and yet it's a big old world of stuff there. But in terms of, it's kind of, I think what you're alluding to is like the top 3 tips that are takeaways. I mean, one idea that got floated that, you know, really I think really could have legs is going back to the, and Juno, I can see your hands floating up there, but going back to the expert patient days, where we have patients who are experts in their field, good communicators, who can communicate with other patients rather than just relying on the clinicians' limited capacity to educate patients. So I think there's definitely something worth following up in there and seeing where we go. There's something as well about the nature of the education that we're providing. I mean, education sits right at the center of all of this in terms of managing, as a diabetic patient, how you manage your condition, and making sure that the education is tailored and suits and fits. And that means we're going to have multiple streams of education. At the moment, it's relatively tightly bound to our existing training courses, which are sort of Desmond and Daphne type courses that most people are familiar with in the world of diabetes. But there's a lot of digital stuff beginning to come over the horizon. We do need to make our training courses more culturally sensitive as well. So, and I think I heard somebody say not just to use the courses for delivering facts, but actually to deliver stuff that's actually relevant and will help the person to move forward with their condition as well, rather than just being able to quote a number of calories in something or whatever it might be. So that's at least 2 things. We did talk as well about improvements in language and one-on-one sort of personalization in terms of treatment and in terms of education as well. But I'll let Juno jump in as well.
Yeah, hi Sue. So yeah, so being a GP, I've got a more medical take on things. Very interesting conversations we had in our group, and the first thing I would say is that when we use the word culturally sensitive, I think that can sometimes give the wrong impression. What we're really talking about in this case is the diet that people have. And, you know, if you're Chinese, you eat mostly Chinese food. If you're African, you probably eat mostly African food. If you're Asian, you might like to eat Asian food. And yet the course is probably talking largely about English food. It should be a relatively easy ask to either go to areas in the UK where they have big populations of, let's say, Nigerians, and maybe even Nigerian consultants in the area, and maybe they've already worked this all up and say, what can we learn from you? What can we share? You know, so I lived in Singapore for a while, so 80% of the population is Chinese. So surely they've done a huge amount of work on what would constitute a healthy Chinese diet for a diabetic. So we either need to go within the UK or even cross-border and say, you know, what can we nick from you, and we can give you something in return. Then we have to ask ourselves, you know, as Dean said, could this be done via an app? So is there already a really good app for, let's say, you know, Asian cuisines or something if you're diabetic? And, you know, we have to co-produce that and ask our patients whether an app is good enough or whether they'd like a person talking about it. And now that there's Zoom and Teams, etc., well, it's very possible to get someone in another part of the country perhaps facilitate a meeting on it. So, you know, there's some quick wins, I think, here. And a really powerful point that someone made was that the 6-hour Desmond program, well, all in one day was a bit much. But more importantly, what the contributor said, which is very powerful, is that you don't have to tell me I shouldn't be eating a cream cake or shouldn't be eating the noodles or whatever. But when I'm feeling stressed, when I've been working long hours or where money's short or tight, how do I stop myself from turning to those naughty things? So perhaps more of a focus on motivational change and behavior change rather than just the facts. We all know what's bad, you know, but how do you stop yourself doing the bad stuff? So perhaps a change in emphasis on the courses a little bit that we are commissioning already, or putting in extra courses that help say, how do I do the right thing when things aren't going well?
Thank you, Gino, really insightful. I'm actually going to hand facilitation back over to Siobhan because I don't want to be the cause of the time.
No problem, Sue. You've done brilliantly. Thank you so much. Okay, if we can quickly then pop to dementia to Ben and Gail.
I've just put something in the comments to say that I'm really keen to work with our diagnostic services and ask them to come out to the communities and actually perhaps bring that service to a community and pilot it to actually really understand what is needed and what they want as well, and also bring the pre and post diagnostic support services as there as well, and really listen and create see if we can get it right in one particular area and then move on to, because it's understanding what is really needed and how we can do that. And I'm keen to work in partnership and take that CMAS diagnostic service out to people if that's something that they would like to work on, and I'm very keen to do that in co-production. So if anyone would like to be involved in that, I'm really keen to sort of work on that and do anything I can. I take away the training and the inclusiveness, and with regards to the kindness aspect, I will make sure that that is fed into our delivering a diagnosis well, and also try really understand what we can do to deliver a diagnosis well, working with communities and really listening, and also to try and understand what went wrong last time, because that for me is really important. What happened with the breakdown, why things didn't work, and how I can build on that, and also just really try and make those services something that people want to use as well. I'm really keen to understand that and why they're not being used, and what those barriers are. So I'm really keen to sort of work with anybody who'd like to work with me and support that further. I'm really passionate about that. Thank you.
Brilliant, Gail. Thank you very much. And we can all see and hear your passion as well, which is fantastic. Thank you so much. If I can now go to cancer.
Yes, I think Peter's put sort of the top 3 in the chat. So what I'll probably do is just fill that out a little bit more, because we did discuss sort of education and awareness. So that I don't think he's put prevention, so thinking about your smoking and obesity agenda, but I think it's also prevention, importance of education awareness of like worrying symptoms of cancer and the importance of accessing screening. So I think it's the whole wide kind of education awareness agenda. And then he's put looking at alternative ways into the system for worrying symptoms of that could maybe be cancer. So we spoke a little bit about primary care and accessing primary care and the barriers to accessing primary care, and you know, does primary care need to hold the key to the next step? Is there a different way we could be doing that? So thinking about self-referral pathways, or pharmacies, or you know, whatever ideas we come up with, I think we need to be really kind of blue sky thinking about what different ways we can access services, including kind of diagnostics and advice. And then lastly, he's put focused screening for at-risk groups, reaching them outside of the healthcare space, e.g. in the workplace. So some really good examples came up in our discussion. So one was a barber shop, I think it was in the Midlands, where did lots of promotion around accessing PSA testing, which is for prostate cancer, blood test prostate cancer, and you know, their rates improved. There's another one about a garage in Sussex did that in the system, trying to access people through the vaccination program for prostate screening. So really looking at those, and I think the key is it's going to people, isn't it? Not expecting people to come to our services, finding where people are, and accessing them in those spaces. So for example, the vaccine centres, where we know we've got hundreds of people in our system going through every day, and you do have that 15-minute wait, where we could be utilising that time differently for people. So it's thinking about that. So I think Dean, I think, has got his hand up, so might have a bit more to comment.
Sorry, so Ben had his hand up. I'm so first, but I'll be super quick. So there are two bits of it. There is the project bit and the culture bit. The project bit tends to be fairly sort of easy. We go to where people are. We increase access to the services. We try to help equity. I think for sustainable change, I think the culture bit is critically important. So I would be very keen, dementia, diabetes, and cancer, for us to have sort of patient sort of representation when the services are being shaped and when the resources are being sort of allocated. Within the social prescribing and personalized care space, that has done our board the absolute world of good, because it really, really has created a bespoke, tailor-made service that meets people where they are. So we don't have to try to fix services to fit with communities. The communities have already designed the services to fit with what they know the need is out there. So for me, beyond the projects on prevention, screening, awareness, getting more information, I think there's a cultural piece there as well, that we probably need to invite the novice, the expert, the person with lived experience at the very, very foundation when the services are being shaped, created, and when the resources are being allocated.
Originally going to be around the dementia, but it works for all of the services, because quite often we, the experts or the team, think we know what patients need, and we don't. And the best thing I've learnt working in this for 26 years as a GP in Ipswich is to learn from your patients and actually put yourself in their shoes and try and walk their journeys. You'll realise while the services that we're providing don't work. And likewise, put yourself in their carers' shoes and their community's shoes, because the solutions, we can't solve it. It's too big. We need to work with the patients, with the carers, and even more importantly, with the communities. They are part of the solution. They have the solution. They don't know it, and we need to help them. So dementia is going to become a bigger thing, like diabetes is a bigger thing. Cancer is the same. And we can come up with great schemes that we think will work, but if we don't check it with the patient, with the carers and the communities, it's not going to work. So the 3 tips for inclusive is talk to your patients and listen to them, and find the quiet ones, find the invisible ones, because they're the ones that are going to fail your system. Then do the same with the carers that look after the patients, and then the community that wraps around, because most patients are not patients. they're supported by their communities and they don't touch us. Especially with BMA, they often deal with one of the reasons they sometimes do badly, they come late because they don't think we're here for them. We don't tell them we are here for them to help them on that journey.
I just wanted to say that I've been working with Refugee Action Colchester for 2 years now, and I've heard some of the most horrific stories that I've ever heard, and the support that's needed. And actually, we do need to go out into those communities. The work that I've done, you have to go out and reach out and find out what they want. And some of them are afraid to come to your GP practices and afraid to come to clinics. And I think there's a lot of things that need to be taken into consideration. And I don't want to just talk about it. I actually want to go out there and try something different and actually see if it works. Because I don't want to talk about it all the time. I just think that it's important to actually try something. If it fails, then let's find out why it fails, but working with the community. I don't want to have another conversation. I've been doing this for 5 years. I've been trying to reach these different individuals, and it just doesn't always work. It's like we're still trying to meet people on the streets and travellers and all our other communities, and we're still asking people to come to us, come to my GP practice, come to my clinic. The work that I've been doing, and over COVID, I just want to get out there in the community and try something. I'm happy to do that. It's not going to work otherwise, I don't think. That's just from my perspective of the work that I've been doing. And I've worked for 18 years across Suffolk. So I'm like others. I just want to see something change, something really positive to change, and actually try it. And if we fail, we try again, but we work together.
Brilliant. Thank you, Gail. That's brilliant. Okay, so I have let this part of the event overrun. I think it was important that we all shared the learning that we got, and I hope that you found the breakout rooms useful. What I'm going to do now is I'm going to pass back now to David very quickly. He was going to talk through the stuff that they did over the Black History Month.
So I was really pleased to be involved in the Black History Month in October 2021. And what we did was we decided that we would try and include healthcare in our Black History Month by looking at people who have made a difference now and in the past. And so that was our campaign. That was our campaign for Black History Month. And the theme was Proud to Be. It was about being proud to be in health and care. And we along with a researcher and our comms people, we set out to find people in the region who had made a difference and who had some pride in the work they'd done for the NHS. So can I have the next slide, please? We wanted to celebrate historical achievements and contributions from Black people and African Caribbean descent to the health and well-being of people in our local communities. It was an opportunity to uncover and share hidden stories and previously untold stories with the help of a young historian, Annie Gray. Stories were gathered through our network to hear about themselves, relatives, colleagues, friends or neighbours whose achievements have so far been unrecognised in working in the NHS health and social care sector. So next slide, please. We had a number of people who we found locally who were still alive, people who have been involved in Black History Month itself regionally. Next slide, please. I'm really proud to say that one of the first people who came up was my dad, Professor Justice Akinsanya. And actually, since we did this Black History Month, I've been back and looked through some of the work that my dad had been doing in the 70s and 80s in this country. And he spoke an awful lot about how health is only going to improve if there's some equality. There's only certain types of people who can navigate themselves around the system, and that actually, he wanted to make sure that other people were involved in the decision making. So we also featured Hamil Clark, who's dedicated his life to the local community, a two-time former mayor of the town and a founding member of the Ipswich and Suffolk Council for Racial Equality. Hamil's contributions to the community have been recognised by several local honours, and he was granted an MBE for services to community relations in 1998. We also had a practising nurse and a vaccine advocate, Josephine Apaya, who has worked to enhance understanding of COVID-19 amongst the local Ghanaian community. Working through COVID, Josephine has additionally run sessions for the local community on COVID vaccines and works with local churches to increase awareness of cancer symptoms. So next slide, please. And in fact, actually, I was very lucky. I was at an event for Africans in the UK the other day, and I got to meet Lawrence Walker, who's another one of those people, and of course Rachel Wharton, who again is somebody I know is doing absolutely fantastic work within the community to try and make sure that voices are heard and that people are getting the practical help that they need through the organisation that she works with. So next slide, please. And luckily, funnily enough, the last person to appear in it was me. And I was honoured for the work that I've done in trying to improve the life chances for those who are looked after. I'm an Essex boy, born and bred, mainly bred in Essex. So I was really proud to have been involved in that, and actually to have my dad at the front and me at the back meant that my family got a lot of pride out of our Black History contribution this year. So I want to thank all of the people who helped us to do that, and to honour the people, not myself, but the rest of the people who were part of the campaign. Thank you.
Thank you, David. That was great. Thank you. And I think we're going to end the event now with Fanwell. He is going to close us down.
Thank you. And just left for me to do the easy bit, which is really to thank you all for attending and participating today. I think there's just a little bit of a reflection that I would like to do today, listening to all the conversations, very, very rich conversations that we've all had. If I think back, when we started this What Are We Missing conversation 18 months ago, for all the people who were in the room, we probably wouldn't have thought that we'd be here today, discussing this same issue. So for that, I really want to thank you all that, we've stayed on with this. And actually, we started talking about COVID-19, specifically, and as you can hear from, the discussions today, that conversation is widening, and rightly so. I mean, I've tried to scribble a few notes as people were talking, but I think if anything, for all its sins, and there are many, COVID has shown us that if we work together, there are things that we can, change within our system. I think, we had, people talking about how things were done differently with the vaccination program and other things, and that is evidence of what you can do if you come together. These, health inequalities that we continue to see today, they are unfair, but they're also avoidable. And I think we've heard today about initiatives that have been done, that continue to be done, where we can, try and change the course that, sometimes we try and that appears as if sort of it's inevitable. If I can just just touch briefly on the issue of it shouldn't be fair that someone's income, that somebody's education, where they live, or whether they've got access to green spaces or healthy food, that should determine their health outcomes. We need to create that equity that we had people talking about, and I think much wider than just health. We need to be looking at how the whole system is responding to this. Yes, more often when we talk about this thing, it ends up being around health, but it's much wider than that, and we need to see partners from right across the system coming together to get involved in these conversations. And sometimes we don't really see that because it ends up being sort of a health conversation. We're now talking about integrated care and sort of getting into some of these
place-based interventions. As Dean was saying, we are trying to create these places where people should be, but these places exist already. People are already there, they're already congregating in the place that they are, and we need to go into those spaces rather than, create these sort of place-based approaches. We need to talk to our communities about how we achieve that. We had some, very good work that is being done, the community ambitions, projects, the 100-day challenges. Let's think about what the good aspects that are coming from that. How do we scale that up? I'm worried that, yes, fantastic work coming from the community ambitions. 2 years from now or a year from now, we will be talking about, we had some fantastic projects that were done a few years ago, but actually we've moved on from that. We're still struggling with some of the issues that we addressed. So how do we embed the learning that is coming from all this fantastic work that we're all, talking about? It's also about accountability, and the purpose of these listening events is really for our leaders, to be accountable, because, at the end of the day, this shouldn't be happening, but it continues to happen. And I think the point that, Susanna mentioned around accountability is really critical. Equality impact assessments are a crucial tool that we could all use. I know they are annoying, many people don't like them. A few years ago, government said we don't really have to do them if you didn't want to, but actually they help in many ways. Firstly, it evidences that, you've thought about the interventions or the decisions that you're making. But actually, it also ensures that as we talk about, true co-production, that we are, thinking about what could go wrong and putting in place the necessary mitigations, for those things. I think the one thing that really stood out for me was Lindsay, and I think Lindsay has said, has left now. She said, our communities do not need to keep repeating their stories. Listening to the different rooms, people were talking about some great work that has been done over a long period of time. But actually, we're still talking about those things, and we're still saying, let's go and ask our communities. We're asking them to repeat exactly the same stories that they told 10 years ago, 15 years ago, 20 years ago. What are we doing with that? We've been doing this, we've been having this conversation for the last 18 months. I'm not saying we should stop, but at every point, let's show how the system is changing as a result of these conversations that we're having, so that people can actually become much more motivated and say, that time I informed the service and look, the service has changed. So if I go back again, I know that, my word is going to mean something. So it is really, important that these conversations, we continue to have them. But the next time we come here, we'll say, when we met on the 30th of November, look at how things have changed as a result of that conversation. And that's the bit that I really look forward to. So, I could speak forever, as many of you know, but I think I want to end here and just say, thank you very much, everyone. Thank you for your contributions, and thank you for taking time, to continue this conversation. 36 months from now, however long, we're still going to be here talking about this, but we're also hopefully going to be celebrating the achievements that we've achieved as a result of coming together like this. So thank you, everyone, and have a good evening.